Would you like to quickly learn how to interpret EKGs for the steps and for your future clinical practice? Here are the only 6 steps you ever need. Coming next.
This is Raj
and Niya with your favorite USMLE channel, where we help you gain in-depth understanding of the high-yield USMLE topics and score phenomenal on the steps.
We're teaching medical content for all steps using our own personally crafted mind maps and algorithm that's gonna make concepts stick.
What you can expect in our videos is a lot of integration, as well as getting a clinical perspective of what's truly important to learn.
Hope you enjoy this video.
Please subscribe to our channel if you haven't already and hit the bell button to receive notifications once we upload new videos.
Thank you for watching.
EKGs can be challenging, especially when you don't have a systematic approach to read them quickly and easily. Try to follow these steps while doing questions at home. Just make sure you don't skip any steps so no detail gets overlooked. The goal here is to get so used to using these steps and this method that on exam day, when pressured by time and emotions, you reading the EKG should happen almost automatically. And it's pretty easy. By the end of this video, the EKG questions might even become your favorite ones. Let's jump into it. Step 0. The ground rule. Always start reading an EKG by looking at lead 2. Lead 2 will give you the best general view of the EKG. Step 1. Check the P waves. So what is the P wave? The P wave represents the depolarization of the atrium. You need to examine all leads for P waves. The most common condition where you won't find P waves is AFib. On the other hand, P waves may be present, but you might not be able to see them if they're buried within the QRS complex, as in AV nodal reentrant tachycardia. Now, a normal sinus P wave is generally upright in leads 1, 2 and AVF, and negative in lead AVR, and its length does not exceed 3 small boxes. The conditions that will change how the P wave looks and in which lead are you going to look for changes? Yes, in lead 2 again, are the P-Mitrale and the P-Pulmonale. P-Mitrale has the characteristic notch or M-shaped form. Its length will exceed 3 small boxes and is seen in left atrial enlargement. On the exams, it will be pretty obvious on the EKGs. The P-Pulmonale, seen in right atrium enlargement, will present with a P wave amplitude more than 3 small boxes. Alright, so let's explain the left and right atrium enlargement EKG characteristics based on this drawing here. So this is how we draw the heart, and just to quickly orient you, this is the right atrium, left atrium, tricuspid valve, mitral valve, right ventricle, left ventricle. From the right ventricle, the pulmonary artery is coming out with the pulmonary valve, and from the left ventricle, we're having the aorta coming out with the aortic valve. Now, where is the impulse generated? It is generated in the sinoatrial node, and it is located in the right atrium. Once the impulse is generated here in the pacemaker of the heart, the impulse travels simultaneously to depolarize the right atrium and left atrium, and after that to depolarize both ventricles, passing through the AV node, through the bundle of His, through the right and left bundle branches, and ending in Purkinje fibers that depolarize both ventricles. Now, having said that, I would like to mention that since the sinoatrial node is located in the right atrium will depolarize slightly before the left atrium. And in normal EKG, if you look at which lead again? Lead 2, you will actually find P waves with a slight M shape, right? And this is completely normal finding. Basically, this slight M shape represents, the first hump represents right atrium depolarization, which happens slightly before the left atrium depolarization presented here by the second hump. And it's very interesting to find. I have actually seen it in normal EKGs. It's completely normal finding. Now, in the pathologic conditions here, in left atrial enlargement, on EKG, we're going to see P-Mitrale. So why do we call it P-Mitrale? Because the most common cause of left atrial enlargement is mitral stenosis, so P-Mitrale. And what we are seeing is P wave, which is longer than 3 small boxes with M shape. Right? So why is it longer than 3 small boxes? So imagine left atrium that is enlarged due to dilation or hypertrophy. It's gonna take, of course, longer to depolarize. That's why the overall P wave is gonna be longer than 3 small boxes. And why does it have this M shape? Because the left atrium will depolarize much later than the right atrium, as it needs more time to do so. That's why we're going to see this prominent M shape with the notch here in the middle. Now, right atrium enlargement EKG findings is the P-Pulmonale. P-Pulmonale, we call it because the most common causes of right atrium enlargement are pulmonary hypertension and pulmonary stenosis, so P-Pulmonale from pulmonary system. And on EKG we're going to see P wave which is taller than 3 small boxes. Why? So imagine in pulmonary hypertension, for example, the blood is going to back up from the pulmonary artery to the right ventricle to the right atrium, which will hypertrophy, right? And since the right atrium is so enlarged, it's going to take stronger electrical currents to depolarize, and on EKG we're going to see this as a tau P wave more than 3 small boxes. And this is the explanation, quick and easy. Moving on. Step 2. Check the peer interval. The peer interval begins at the onset of the P wave and ends at the onset of the QRS complex, and represents the time the impulse takes to reach the ventricles from the sinus node. The normal duration of this interval is between 120 and 200 milliseconds, or between 3 and 5 small boxes respectively. Short PR intervals are suggestive of Wolff-Parkinson-White syndrome, whereas PR interval longer than 1 big box, consisting of 5 small boxes, or in other words more than 200 milliseconds, is suggestive of AV blocks. Let's quickly go over the AV blocks as they're heavily tested, but more detailed information you can find in our arrhythmia videos. Alright, so the AV blocks are characterized by a peer interval more than 200 milliseconds, and we have 3 types: first degree, second degree and third degree. Now the first degree is the easy one, it just has the prolonged peer interval, and if the patient is asymptomatic you do not need to treat him. The second degree is the interesting one. It's subdivided into Mobitz 1/Wenkebach and Mobitz 2. Now who are these people? Let's put faces on them. Mobitz was actually a Russian-German physician who in 1924 subdivided the second degree AV block into Mobitz 1 and Mobitz 2. And he did this with the help of the EKG. And who invented the EKG? Yes, Eindhoven in 1903. And by the way, he won a Nobel Prize for this invention, which I think he totally deserved. Now, Wenkebach was a Dutch physician who described the same AV block, but without the help of the EKG in the early 19th century. Now, I tend to tell you these historical facts here and there, so maybe I can help you remember stuff better and faster if you make a cool connection in your mind, the way I do, and I'll show you how in a second. Now, the Mobitz 1 is characterized by progressively increasing peer interval until a beat is dropped. Right, there is a P wave, but there is no QRS, which means that the impulse generated in the sinoatrial node is not conducted to the ventricles. Now, once this beat is dropped, the peer duration will go back to the initial one. So this cycle can repeat again and again. Okay? Now, if the patient here is asymptomatic, you do not need to treat him. But if the patient has signs and symptoms, you can give him atropine. Instead of just memorizing the drug, you can try to understand how it works, and once you do that, this information will stay in your mind forever. So the heart has sympathetic and parasympathetic innervation. The sympathetic one causes tachycardia, whereas the parasympathetic one causes bradycardia. How? Via the vagus nerve. The vagus nerve releases acetylcholine, which goes and binds to the M2 receptors of the sinoatrial nodal cells, which are the pacemaker of the heart. Once acetylcholine binds to them, it causes their hyperpolarization via decoupled intracellular signaling pathways, thus decreasing their firing rate. Now, in AV blocks, you have increased vagal activity, and you want to block this. How? With atropine. So atropine, what it does is it comes and it binds to these M2 receptors, thus blocking the acetylcholine action on them, thus improving the heart rate. Easy, right? Now I have a cool question for you here. Imagine a patient with a transplanted heart having bradycardia. Do you think atropine is gonna work there? No. Why? Because the heart that has been transplanted has been denervated. There is no vagal innervation there. So even if you give atropine, it's not gonna work. Instead, what you want to do is stimulate the sympathetic beta-1 receptors that are located on the sinoatrial node of cells, so you can increase the heart rate. And you do this with isoproterenol, terbutaline, and theophylline, which are beta-1 agonists. And if this fails, you can of course place a permanent pacemaker. So I hope this quick explanation helps you remember and understand why we use atropine in AV blocks. Now MOBITS 2 is characterized by constantly increased peer interval followed by sudden drop of a beat. And since it can progress to third-degree AV block, you have to put pacemaker even in asymptomatic patients. Now here I would like to share with you my trick of remembering which MOBITS had the progressively increasing PR interval. And since now I know a little bit of MOBITS and Wenckebach's historical background, I know that they both describe the same AV block but with and without the help of the EKG. So now I can use the way Wenckebach sounds to connect it with the way PR lengthening sounds. So check this out. Wenckebach, lengthening. And one more time. Wenckebach, lengthening. Don't they sound the same? Yes, they do. Alright, moving on to third-degree AV block characterized by independently contracting atria and ventricles. As you can see here, P followed by P followed by 2 QRS complexes. And since it can cause sudden cardiac death, we have to put pacemaker even in asymptomatic patients. Okay, so this was the quick recap of AV blocks and we are moving on. Step 3. Check the QRS interval. The QRS interval corresponds to the depolarization of the right and left ventricles. Normal QRS interval is less than 120 milliseconds, or less than 3 small boxes. If the QRS interval is longer than 3 small boxes, then what you should do is look at the QRS in V1. If the QRS in V1 is upright, that means you have diagnosed right bundle branch block. If the QRS in V1 is downright, you have diagnosed left bundle branch block. It's that easy. Here you can also look for electrical alternance, which is an alternation of the QRS complex amplitudes and is seen in large pericardial effusion. You can also look for delta waves. A delta wave is an initial shallow upstroke before each QRS complex and is indicative of accessory pathway. On EKG delta wave, wide QRS and short PR is known as Wolff-Parkinson-White syndrome. Step 4. Check the QT interval. The QT interval reflects the time required for both depolarization, which is the QRS complex, and repolarization, which is the T wave of the ventricles. It's measured from the beginning of the QRS complex to the end of the T wave. You want to check if it's prolonged or not. Quick way to determine if it's prolonged is if it's more than half the distance of the preceding RR interval. But it works only at normal heart rates, which is heart rate between 60 and 100 beats per minute. Also keep in mind that the QT can be shortened due to 2 main reasons. One is mutations in cardiac ion channels genes, which is a very rare proarrhythmic condition, characterized by QT less than 360 milliseconds and leading to sudden cardiac death. And the second one is hypercalcemia. And since I mentioned sudden cardiac death, another very rare cause of sudden cardiac death in young patients less than 35 years of age, especially athletes and military recruits, is the anomalous aortic origin of the coronary arteries. Keep this condition in mind as it might show up on your tests. Now you must have heard of the Bazet formula. Here's what it is. Normally the QT interval varies inversely with the heart rate. Therefore, we need to find a way to adjust it for the different heart rates. So how do we do that? Well, the EKG machine, as you can see on this EKG strip, gives you a corrected measurement, the so-called QT-C. But the thing is that this value has to be confirmed, and the most commonly used rate correction formula was developed by Bazet, and I have shown you how to calculate it here. Now on the steps, you won't be asked to calculate the QTC. When you start residency, you'll see that this is usually done by cardiology fellows. And to calculate the QTC is actually a cardiology board exam question. But regardless of that, if you want to do well in residency, I strongly suggest you know that formula and what it is. Apart from Bazet, there is another formula you must be familiar with, the Hodges formula. In cases where the heart rate is more than 110 beats per minute or less than 60 beats per minute, the Bazet formula tends to overcorrect and undercorrect, respectively, the QT interval. So we use the Hodges formula in those cases. On the steps though, they will give you the value of the QTC and ask you for the diagnosis or what you're going to do next. That's why you need to know the following values. QTC less than 440 milliseconds is normal for both genders. More than 450 milliseconds in men and more than 470 milliseconds for women means long QT syndrome. So you need to evaluate the patient for any acquired or congenital conditions causing this. Okay, let's start with the congenital conditions first. The most common autosomal dominant congenital syndrome is the Romanov-Ward syndrome, and it has a purely cardiac phenotype. It's caused by mutations in genes coding for potassium and sodium transport channels in cardiac cells. Whereas the autosomal recessive form, the Jervell and Lange-Nielsen syndrome, is associated with long QT syndrome plus sensory neural deafness from birth and has more malignant clinical course. The mutated genes here code for a channel that transports potassium ions out of the cell. The movement of potassium ions through these channels is critical for maintaining the normal functions of the inner ear too. That's why, in addition to the cardiac presentation, you see here the bilateral sensory neural deafness also. Detailed and super easy explanation of the cardiac action potentials you can find in our Step 1 cardiology videos. Okay, the acquired long QT syndrome can be caused by three major groups, as you can see here. Some of the most common medications that can use QT prolongation are the class 3 antiarrhythmics, amiodarone, sotawol, ibutilide, dofetilide, as well as class 1 antiarrhythmics, quinidine, procainamide, the antipsychotics tioridazine and ziprasidone, some antibiotics like fluoroquinolones and macrolides, ondansetron and metoclopramide, which are both antiemetics, the TCAs and SSRIs, antifungals, the ranolazine, which is anti-anginal medication used in stable angina as a last resort drug after initial management fails, diuretics, and many more. Some of the diseases that can prolong the QT are heart failure, left ventricular hypertrophy, bradyarrhythmias, hypothyroidism, and hypothermia. And of course the electrolyte disturbances. The most common ones are hypokalemia, hypomagnesemia, and hypocalcemia is less common. These electrolyte disturbances will be briefly discussed at the end of this video too. Last but not least, we have to talk about the famous Torsades-de-Pointes, which is associated with long QT, polymorphic QRS, VTAG of 150 to 250 beats per minute, and sudden cardiac death. Torsades in patients with acquired long QT syndrome is most commonly triggered by premature ventricular beats, followed by compensatory pause, the so-called short-long RR interval, that initiates the cycle of VTAG. If the Torsades is provoked by bradyarrhythmia, we call it pause-dependent long QT syndrome. Torsades has such a characteristic pattern that you won't miss it on the exams. And remember, you treat it with IV magnesium sulfate, even in patients with normal magnesium serum levels. If this doesn't help, you can insert temporary transvenous spacing, especially in the pause-dependent long QT syndrome. More information on arrhythmias in our arrhythmia videos. Step 5. Check the ST segment. The ST segment occurs after ventricular depolarization has ended and before repolarization has begun. The diagnostic criteria for STEMI, which is ST elevation myocardial infarction, are new ST elevation at the J point in 2 or more anatomically consecutive leads, with the characteristics you are seeing in the purple box. The most common etiologies for ST changes include STEMI, left bundle branch block, left ventricular hypertrophy, normal early repolarization, pericarditis, left ventricular aneurysm, vasospasm, severe hyperkalemia, hypothermia, Brugada syndrome, which is a condition with inherited sodium channel defect, right bundle branch block, and ST elevation in V1 to V3, and the Takotsubo cardiomyopathy, the so-called broken heart syndrome. Now, it's very important for you to know what is the J wave, or the so-called Osborn wave or hypothermic wave. J waves are positive deflections occurring at the junction between the QRS complex and the ST segment. Most prominent it leads V2 to V5. And what makes them so important is that elevation in the J point can mimic STEMI. So be aware of that, because J point elevation can be completely normal finding in asymptomatic patients. ST changes in acute ischemia start with T-wave inversion, progress to ST segment elevation or depression, and finally result in Q waves. Pathologic Q waves are greater in height than a third of the subsequent R wave. Remember that any process, acute or chronic, that leads to scarring of the cardiac tissue can result in Q waves. For example, dilated cardiomyopathy, myocarditis, scleroderma, sarcoidosis, Duchenne muscular dystrophy, which by the way mimics posterolateral infarct, and others. Transient Q waves can also occur with myocardial ischemia, without infarction, and with certain metabolic disturbances such as hyperkalemia, as well as with the stress-induced Takotsubo cardiomyopathy. Q waves are also one of the reasons why we cannot perform a normal exercise stress test on a patient with symptoms suggestive of stable angina and previous history of STEMI. Why? Because the presence of a Q wave can mislead us. In such case, what do? We do the exercise plus thallium or exercise plus echo stress tests. We have elaborated great algorithms for approaching acute coronary syndromes, so you can check that video as well. Let's discuss how we can localize the MI based on the EKG findings. First, let me show you what I have drawn here on the board. This is the heart with its 4 chambers and the vessels coming in and out of it, and these are the 12 leads of the EKG. V1 to V6 are the chest leads, whereas the rest of them are the peripheral leads. AVL is placed on the left arm, AVR is on the right arm, and AVF is placed on the left foot, whereas 1, 2 and 3 represent the connection between them. 1 is the connection between AVL and AVR, 2 is the connection between AVR and AVF, and 3 is the connection between AVL and AVF. Now let's discuss ST elevation first. If you see ST elevation in V1 and V2, you have diagnosed anteroseptal MI. Why is that? Because V1 and V2 are placed exactly on top of the interventricular septum. And which artery supplies it? The left anterior descending artery, which by the way is one of the 2 branches of the left main coronary artery. The other one is the left circumflex artery. Now by the same logic, if you see ST elevation in V3 and V4, you have diagnosed anterior wall MI, and again you're going to look for occlusion in LAD because it supplies the anterior wall too. Now if you see ST elevation in the lateral leads, which are V5, 6, 1 and AVL, you have diagnosed lateral wall MI. And which artery supplies it? The left circumflex artery. And if you see ST elevation in all leads, what are you thinking of immediately? Pericarditis, yes. And the other finding that is as important as ST elevation in all leads is the PR depression in all leads, so keep this in mind. And quickly, what are the most common causes of pericarditis? Idiopathic and Coxsackie virus. Pay attention to the virus part because they're going to ask you specifically about it. How do we manage it? NSAIDs, most commonly aspirin and colchicine. And another type of pericarditis that I would like to mention is the post-MI pericarditis. It's subdivided into early and late post-MI pericarditis. The early one happens less than 4 days post-MI, and the late one, as we all know, is called Dressler syndrome. Moving on to the inferior wall MI, and let's see why is it so important. First, how can we diagnose it? With ST elevation in the inferior leads, 2, 3 and AVF. Now, which artery supplies the inferior wall is the right coronary artery. But apart from that, it supplies the synovial node, the AV node and the right ventricle. Now, since almost half of the inferior wall MI cases involve the right ventricle, you want to make sure if the right ventricle in your patient is involved or not. How do you do that? You take the chest leads and you put them on the right side to encompass the right ventricle. starting from the sternum going back to the spine, V1, 2, 3, 4, 5 and 6. And if you see ST elevation in the right side at V3 to V6, you have confirmed right ventricular MI. And so what? Why is it so important? Because its management differs greatly from the usual STEMI management. Normally we give them nitroglycerin. Here in our case you should never ever give them nitro, because it's a venodilator, and by being such it will decrease the preload to the heart. And our infarcted right ventricle is very much dependent on preload. Instead, what you want to do is increase the preload by giving them IV fluids. Now, why is it so dependent on preload? Check this out. Even though the right ventricle is infarcted and it's not pumping properly, it still pumps a little bit. So by you giving IV fluids, you're basically increasing the preload, increasing the blood that's coming back to the right ventricle, and thus increasing the blood that's being pumped out of the right ventricle to the lungs, right? And eventually it's gonna end up in the left ventricle. Now, by returning more blood to the left ventricle, you're increasing the blood that's going out of the left ventricle, basically increasing the cardiac output. And by doing so, you will improve the systemic blood pressure, which is typically very low in patients with right ventricular MI. You will also improve the perfusion of your heart. Why is that? Let's remind ourselves that the sinuses of Valsalva, that give rise to the right and left main coronary arteries that supply the heart with blood and oxygen, are located just above the aortic valve. So by keeping the cardiac output high, you will increase the perfusion of the heart, right? So now, because the right ventricular MI management is the exception to the rule, you should really understand why we treat it the way we do, so you can successfully apply this knowledge on your tests and in your future clinical practice. Lastly, let's discuss the posterior wall MI, as it can be challenging to diagnose because it presents differently. Imagine a patient comes to the ER with typical chest pain and you suspect STEMI. You do an EKG, but you don't find any ST elevations. So what's happening? Here you have to remember that the posterior wall of the left ventricle is not directly visualized by the 12-lead EKG. So instead of you looking for ST elevations, you have to start looking for its reciprocal changes, which are ST depression in V1 to V3. Now, what are reciprocal changes again? It basically means that the EKG leads that are directly facing the acute myocardial injury will have ST elevations on them, whereas other leads will have ST depressions. And here you can see a table with the reciprocal leads. Now, once you find these ST depressions in V1 to V3, you have to start suspecting posterior wall MI. And in order to confirm it, you have two methods. The first is by you taking the chest leads V4, 5 and 6 and placing them under your left scapula, thus becoming V7, 8 and 9 leads. And in this way they will be directly facing the posterior wall of the left ventricle. And if you find ST elevations there, you have confirmed posterior wall MI. Now, the second method, you won't be able to use it on your test, but you will see your attendings using it during your residency. So what they do is they take the EKG and they flip it upside down. Then they hold it onto the light and basically they will see the same changes. Step 6. Check for axis deviation. The axis deviation helps us determine if there is ventricular hypertrophy or not. The most efficient way to estimate the axis is the 3-lead analysis, using leads 1, 2 and AVF. As you can see from the table I have drawn here, the normal axis has upright or positive QRS complexes in all 3 leads. Left axis presents with QRS complexes positive in lead 1 but negative in lead 2 and AVF. The most common causes include left ventricular hypertrophy, which by the way can be a normal finding in the elderly, conditions that push up the diaphragm like pregnancy, ascites, abdominal tumors, as well as left bundle branch block and inferior wall MI. This of course is not a complete list. If the QRS complexes are negative in lead 1 and positive in leads 2 and AVF, then the axis is rightward, which is a sign of right ventricular hypertrophy, pulmonary hypertension leading to right ventricular failure, mechanical shifts such as inspiration and emphysema, right bundle branch block, dextrocardia, lateral wall MI, and others. Extreme access is observed in conditions like VTAC, hyperkalemia, and severe right ventricular hypertrophy. And on EKG, we'll see negative QRS in all three leads. The voltage criteria most clinicians use as a quick bedside method to determine left ventricular hypertrophy are the following: S in V1 plus R in V5 or V6 more than 35 mm, or the Cornell criteria: S in V3 plus R in AVL more than 28 mm for men and more than 20 mm for women. And for the right ventricular hypertrophy, we measure the R in V1. If it's more than 7 mm, we have confirmed the diagnosis. You also need to know what changes to expect on EKG with different electrolyte disturbances. We'll discuss 4 of them. More details will be provided in the nephrology videos, but here is a quick recap. We'll start with hyperkalemia. When presented with hyperkalemia, the first thing you need to do is repeat the blood work. If the elevation is confirmed, you have to do an EKG on this patient. If you find EKG changes as the ones I have listed here, what you must do stat is give calcium gluconate to stabilize the cardiac cell membrane. If they ask you how can you put the potassium back into the cell, pick bicarbonate or insulin plus glucose. Hypokalemia, less than 3.5 milliequivalents, delays the ventricular repolarization, leading to reentrant arrhythmias. EKG might show T-wave flattening, U waves, premature atrial and ventricular contractions, multifocal atrial tachycardia, ST segment depression, AV block, and cardiac arrest. One of the most tested reasons leading to hypokalemia is hypomagnesemia. So always check the magnesium levels in hypokalemia and keep the magnesium always above 1. The leading reason for hypomagnesemia is chronic alcohol consumption. And this is a very high yield question across all steps. Treatment is with potassium repletion. The rates are as follows: less than 10 milliequivalents per liter per hour if you're using peripheral line, or less than 20 milliequivalents per liter per hour via central line. I would like to briefly discuss here the U wave. U wave is a positive wave after the T wave. It's generally seen in leads V2 to V4. And U waves may be seen in normal individuals, and their origin is uncertain. But apart from hypokalemia, bradycardia, class 1A and 3 antiarrhythmic drugs, and intracranial hemorrhage can also increase their amplitude. Negative U waves during exercise testing have been reported to correlate with significant stenosis of the left main or left anterior descending coronary artery. Moving on to hypocalcemia. Hypocalcemia presents on EKG with long QT interval. When you see calcium levels less than 8.4 mg per deciliter, you must always correct them with the formula you're seeing in the white box. If the corrected value is in the normal calcium reference range, then the reason for the hypocalcemia is hypoalbuminemia. Also, always check the magnesium levels. Both hypocalcemia and hypokalemia will not correct if you don't correct the hypomagnesemia first. Hypocalcemia presents with the Chvostek and Trousseau signs. The Chvostek sign describes the twitching of the facial muscles in response to tapping over the area of the facial nerve. Trousseau is the name of 2 distinct phenomena, both named after the French internist. Trousseau sign is a carpal spasm elicited by placing a blood pressure cuff on the arm and inflating it slightly above the systolic pressure. The other phenomena is the Trousseau syndrome of malignancy, aka migratory thrombophlebitis, which is recurrent and appears in different locations over time. It's most commonly seen with pancreatic cancer and adenocarcinoma of the lung. Lastly, we have hypercalcemia, which presents on EKG with short QT interval. Other manifestations include osteopenia and fractures, kidney stones, anorexia, constipation, weakness, psychiatric manifestations like altered mental status and fatigue. I'm here to show you a cool way to understand how hypo and hypercalcemia can give you the physical presentation that we discussed earlier in the slides. So let's deal with hypercalcemia first. Imagine this is a neuron, every cell has a resting membrane potential. For the neuron, it's minus 70 millivolts. This potential is determined by the uneven distribution of ions, which means that inside the neuron we have relatively more potassium ions, and outside the neuron we have relatively more sodium ions. In order for this neuron to depolarize, meaning to fire, you need the sodium to come inside the cell. And it does so via this sodium channel. It depolarizes the neuron and the neuron starts firing. Now what happens normally is when you want this process to cease, calcium comes, sits on top of this channel and it blocks it. So it stops the sodium influx. So it stops the depolarization of the neuron. Now in hypercalcemia, you just have too many calcium ions. So this channel will be constantly blocked. So it will be very difficult for the neuron to depolarize. And this is how we explain the physical symptoms. Imagine the nerve cells that are supplying your skeletal muscle. If they're not firing, your muscle won't be contracting, so you will feel weak. Imagine the nerve cells in your brain are not firing. You will feel depressed, confused. Imagine the nerve cells that are innervating the smooth muscles in your gut. If they're not firing, the smooth muscles are not contracting, and you end up with constipation. This is how, with one phenomena, we can explain all these physical symptoms. Cool, right? Let's discuss hypocalcemia now. Again, this is our neuron with resting membrane potential of minus 70 millivolts. But what do you think is going to happen with the sodium channel in hypocalcemia? Yes, it will be constantly open. Why? Because there's just not enough calcium to close it. So there will be constant influx of sodium ions inside our neuron. And what do you think is going to happen with our resting membrane potential? Yes, it will increase from minus 70, let's say it goes up to minus 30 millivolts. This will make the neurons hyperexcitable. That's how we can explain Chvostek's sign. So what he would do is, he would tap at the angle of the jaw and he would see this. Why is this happening? Because he's tapping on top of the hyperexcitable facial nerve. And this hyperexcitable nerve needs just a little bit of a tap to depolarize and to fire, thus causing the muscles it's applying to contract. Easy, right? Why would you feel anxious? Imagine the nerve cells in your brain are constantly firing. Yes, definitely you would feel anxious and irritable. Now in Trousseau's sign, we observe constant carpal spasm here by putting a blood pressure cuff and inflating it. Why is this happening? Now in hypocalcemia you still have a little bit of calcium flowing around. But if you cut the blood supply to your distal arm by inflating this blood pressure cuff, from having less calcium you end up having no calcium. That's why we see this sustained carpal contraction. And this was the explanation of how hypo and hypercalcemia give you the physical presentation we observe. So we are at the end of our EKG video, so let's do a quick recap. Step 0 was our ground rule, to look at lead 2 so you can get the best general view of the EKG. Step 1 was check the P wave. You're looking here for sinus rhythm. If every P wave is followed by QRS complex, you have sinus rhythm. If it's not, you're looking at some sort of arrhythmia. Also here check the P wave morphology and look for P-Mitrale P-Pulmonale. Step 2 is check the PR interval. If it's increased more than 200 milliseconds, you are thinking some of the AV blocks that we discussed. Step 3 is check the QRS interval. If QRS is more than 120 milliseconds, check the V1. If the QRS in V1 is pointing downwards, then you have diagnosed left bundle branch block. If QRS in V1 is positive, pointing upwards, then you have diagnosed right bundle branch block. Now step 4 was check the QT interval. Here you have to remember the values. QTC less than 440 milliseconds is normal for both genders. QTC more than 450 milliseconds for men and more than 470 milliseconds for women is long QT syndrome. So you have to look for any acquired or congenital causes. Right? So step 5 is check the ST segment. Here you have to memorize the STEMI criteria, as you will be needing this for your steps and in your clinical practice. And step 6 was check for axis deviation. Here you're looking for ventricular hypertrophy, and remember that we discussed the 3-lead analysis and the voltage criteria. So that's it, quick and easy. And whenever you feel overwhelmed, just remember the famous words of Deborah Evans: life is like an EKG. Without the ups and downs, you're not living. Or just go out and get some fresh air, relax for a second. Because guys, the USMLEs are a marathon, they're not a sprint. I hope you found this video useful. If you have any questions, leave them in the comment section below. I'm always very happy to help. And most importantly, enjoy what you're learning. See you in the next video.